I do want to thank everybody for joining us this afternoon. I see a lot of familiar names on the roster, and I know this will be hopefully as exciting information for you all as it will be for our guests. So very excited to get this presentation started, and I'm really excited to talk about this topic, which during these circumstances is even more important, because what we know is that the data has shown that in some cases severity, the numbers, and the capacity has made sexual and domestic violence, intimate partner violence, a more complicated situation during the COVID-19 pandemic. So we thank you all for joining us. I will begin with a couple of housekeeping notes. I'll start with an introduction of myself. My name is Davis Gammon. For those of you who weren't on the call last week, I'm a program manager at the Virginia Hospital and Healthcare Association, and working within the Population Health Department. And I'm the program manager of the Hospital-Based Violence Intervention Program grant, of which we are a recipient. Just a couple housekeeping notes. Two, we're going to keep all of your lines muted so we can limit the background noise and allow our experts and our presenters to give you the great information that you've come here for. But we know that information is going to spark a lot of questions. So we really want you to have those questions, and as you have them, put them in the chat, and we'll get to those at a designated time towards the end. As we speak, this webinar is going to be recorded and will be sent out for those that couldn't attend and for those that want to share it with others. So without further ado, I'm going to introduce or turn it over to our presenters to introduce themselves. I'll start with Bonnie Price. Bonnie, do you want to introduce yourself?
Sure. My name is Bonnie Price. I'm the Administrative Director of Community Health Advocacy for Bon Secours Richmond Hospitals. And my areas of focus include the Forensic Nursing Program, human trafficking, workplace violence, trauma-informed care, and the opioid epidemic.
Thank you so much, Bonnie. And Ruth, would you like to introduce yourself?
Sure. Good afternoon. My name is Ruth Micklem, and I'm the Community Initiatives Manager for the Virginia Sexual and Domestic Violence Action Alliance, which is a statewide coalition here in Virginia that provides support, technical assistance, policy initiatives to all the local domestic violence and sexual assault agencies. And I have been working here in Virginia in the domestic violence and sexual assault field for over 30 years. So I'm excited about the work that's happening, and I'm really excited to be here today.
Thank you, Ruth. So this slide is just to remind us that this is part 2 of the hashtag Violence as a Healthcare Issue webinar series. We've had the first one, which was an introduction to violence in COVID-19, the pandemic, which was a great success, and we appreciate everybody who was able to join us. If you weren't able to join us for that, recordings for that should be posted today, and we'll provide more information to you all as it's available. And recordings for this webinar will, as I mentioned previously, will be sent out as that is made available as well. We do want to make you aware of next week's webinar, which is going to be on June 3rd, 2020, from noon to 1. And the presenters for that is going to be from VCU Health, and they're going to speak primarily on gun violence and community violence. And this will really kick off Gun Violence Awareness Month, and we'll have more information about our activities around Gun Violence Awareness Month at the end of the presentation. So just please mark your calendars for next week as well. And again, I apologize for the time mix-up for this webinar. I hope everyone was able to get here and arrive to the webinar and is ready to hear some exciting information. All right, and without further ado, I'm going to turn it over to Bonnie to begin our presentation. Bonnie, you can take it away.
Thank you, Davis. Ruth and I had some conversation regarding this presentation that we're about to give you. And one of the things that we both thought was really important for us to talk about was how to do or how to provide care for victims of violence in a trauma-informed manner. That term gets used a lot, trauma-informed care in trauma-responsive institutions. To me, trauma-informed, one of the basics of trauma-informed care is giving the patient choices about what their options are, informed choices. So you'll hear Ruth and I talk about that quite a bit throughout our presentation regarding sexual assault and domestic violence. And just to take a step back, the last presentation we did was an overview of general information taking care of IPV and domestic violence patients. This one we're going to dig a little bit deeper into taking care of patients with who report being sexual assault, victims of sexual assault, and then some screening options as well. And we encourage you all to please type in your questions. Polly is monitoring our chat room over there for us, and we'll leave some time for questions. So please don't hesitate to ask. Usually when I present, I talk a lot with my hands. For those of you who can see me on the screen, you can't see my hands, so I'm feeling a little stymied, but you might see me raise my hands once or twice just to see if you're paying attention. So let's start with what choices do patients who come to a healthcare facility reporting that they've been sexually assaulted, what choices do they have? They have three choices. First, they can have a forensic exam, and by forensic exam, I mean documenting any type of injuries they have, gathering a history, having evidence collection, and medications, which we're going to talk about later, as well as safety planning. And we can assist them in reporting to law enforcement. The second option is they can have all of those things with a forensic exam. However, they can also choose not to report to law enforcement, and this is known as a blind or anonymous kit. The Violence Against Women Act mandated that hospitals needed to provide patients with the option of having evidence collection without having law enforcement involvement. And I think it's a very important option for our patients. If you can only imagine coming in, having just been traumatized, and that feeling of having to make lots of decisions right then, you know, do I want to take HIV meds? You know, where am I going to go when I leave here? Am I safe? Are my kids safe? Do I have resources? And then have to make a decision as to whether I want to speak with law enforcement at that moment or have evidence collection. It can be extremely overwhelming for the patients. And so with the blind or anonymous kit option, it gives patients a chance to slow things down for a moment and make a decision as to what might be right for them. But the final decision as to what they do with that evidence, they have some time. So with a blind or anonymous kit in the state of Virginia, it actually is sent to the Virginia Division of Consolidated Labs. They will hold the kit for 2 years, and patients can write a letter requesting that it be held for up to 10 years. So if you have a patient who really is unsure what they want to do, please offer them the option of having an anonymous kit, letting them know that it is completely confidential. Their name is not put on the outside of the box anywhere. We use a number, a generic number. No one knows that that kit was collected except the patient and I. It's mailed in a sealed box to the consolidated lab where it stays on the shelves of the consolidated lab until the patient goes back and says either they would like to have a report to law enforcement, or if the time comes and the kit is destroyed. Just so everyone knows, that there are downsides to anonymous kits. So I do think it's important for our patients to understand that too. The downsides are that you can only include the evidence that will actually fit into a physical evidence recovery box, which isn't a huge box to begin with. So if there's a lot of clothing, that may not be able to be included. Drug screen kits, so blood and urine samples cannot be placed into an anonymous kit because, as I mentioned, they're placed on the shelf. They're not refrigerated. So that's a downside to it. So you just want to make sure that the patient knows the options and the risk and benefits either way of what they choose. And then the third option is we have some patients who come to us and they know that they do not want evidence collected. They do not want to have photographs. They want to make sure that medically they're okay. And so we want to make sure that we provide them with STD testing, pregnancy testing, prophylaxis, medications, and make sure medically that everything is okay, as I said. So there are three options. Frequently, patients worry about costs associated with these exams, which I completely understand these days with the cost of healthcare. There are resources available to cover the cost of the forensic exam. And by the way, hospitals across the country actually are required to provide a forensic exam free of charge to the patient. Now, if there's medical care, that's separate, but the evidence collection, patients cannot be charged for that portion of the exam. Davis? So I just wanted to give you a resource. The group that assists with paying for the forensic exams is called the Virginia Victims Fund. It used to be called the Criminal Injuries Compensation Fund, if you're familiar with that name. There are two pots of money. One goes to reimbursing for forensic exams. The other pot of money actually assists victims with other needs. For example, if they need to move, they want to have their locks changed on their doors, they need transportation. There are a number of things. Counseling falls into that other bucket of money. So there are other resources. And the Hospital Violence Intervention Program that a number of us on this call today have started, this is a great resource for the advocates to use for funding for the victims. So I wanted to start at the beginning. Once you've had a chance to talk with the patient and offer them options, you're also assessing them for what medical needs they have. Keep in mind that medicine always takes precedence over forensics. And what I mean by that is, you know, over the 27 years I've been doing this, there have been times when I've been called by the providers and they've said to me, well, you know, you're here, hands off, I'm done, my part's finished, there's nothing else I need to do. We need to make sure that our healthcare facilities know that if the patient has some type of injury that absolutely needs to be addressed, they need to be assessed for any type of injuries that they might have. And if you can have a plan in place to coordinate with the forensic department that you use, as say, for example, what clothing do you take off and what do you leave on to preserve potential evidence? How do you protect the evidence while also making sure that you take care of the patient medically? There's lots of things that the forensic department can help your healthcare facility talk through as we're determining the needs for the patients. So these are the basic steps of a forensic evaluation, and I'm going to preface some of it with whether there's a forensic nurse available or not. So all healthcare providers, we want to make sure, again, that the medical needs receive top priority with these patients. A forensic history. A forensic history is a bit different than a history that the healthcare provider may collect who does not have forensic training, or if they may not have a forensic program. A forensic history really guides how we're going to collect the evidence. so we need to know things like when the event happened, how the event happened, positions that they may have been in, if there could be cross-contamination of evidence, what type of evidence I might need to look for. So it's going to be a more detailed history. We, at our facilities, encourage our emergency department staff that when a patient reports to them that they are a victim of assault, that their history be very minimal. And the reason being is because I would hate for the patient to have to tell their story more than once. Many of you all have heard that victims of violence, from the time they call 911, if they call 911, till the time they arrive at the hospital, they could have told their story 14, 15 times. So you want to look at your process and find ways to minimize how many times they're telling their history and who they have to tell that history to. Of course, in the forensic exam, we're going to be doing a detailed physical assessment, photographing any of the injuries, documenting anything that we see. In a genital exam, we're going to be using a PERC, or physical evidence recovery kit. We use UV light to help look for potential body fluids. Some programs also use UV light to look for subdermal bruising. Colposcope, which is basically a microscope on wheels that helps us to see any type of very small micro trauma that might be there during the exam. The next step is we want to provide medications, and so you want to make sure your program or a hospital that you're referring to provides the patient with medications to decrease the risk of sexually transmitted diseases, of HIV, and pregnancy options. All of those need to be discussed. A discharge and safety plan, which we all know as healthcare providers, starts at the very beginning of the conversation, making sure that they can get home safely. Again, advocates, whether it's a hospital violence prevention advocate or it's your local community-based program advocate, they can absolutely help with the discharge and safety planning. And then maintaining chain of custody. So everything that you potentially collect, you want to be sure that there is a chain of custody as to who touched it, who collected it, what happened to it, dates and times. And I can tell you over the 26 years, they question our chain of custody more now than they ever did when I first started this, and rightly so. So you want to be sure you have a good documentation log of where things went and who gathered what. So what's the current time frame for collecting biological evidence? Right now it's 5 days. And I say 5 days because I think the research is constantly evolving when it comes to biological evidence. And what I mean by biological evidence is potential DNA. So blood, urine, seminal fluid, cells, anything that you might collect in that physical evidence recovery kit. And as research has improved and testing has improved, the ability for the forensic scientists to test the data or test the material that we send them has increased. So there's even some research studies that show it may, there still may be biological evidence up to 28 days. And there's also research that shows it may be in females until their next menstrual cycle, because the flow of the cycle may potentially wash the fluid out. But before that, there still may be some biological evidence present. I will tell you that if a patient is anywhere in that 5 to 6 day range, and I think there's still a potential for evidence, go ahead and offer it. It's not going to hurt if the patient wants to have evidence collected. Again, it's their choice. Now, of course, you want to let them know that the potential for having evidence is going to decrease as the hours go on, but it certainly doesn't hurt anything to try and collect the evidence. Just a few things regarding crime scene preservation. Many of us probably have learned this throughout the years, but eat, drink, use the bathroom, smoke, change clothing, bathe, and wash. And the reason we bring these things up is because you don't want to potentially destroy evidence. Now, I want to caution you to not just check a box and say, okay, you can't eat, you can't go to the bathroom, you can't smoke. Because, again, it's the patient's choice as to whether they do these things. And while they may potentially hinder evidence collection, we don't want to take that choice away. And Ruth, you have a great way of kind of explaining that in a trauma-informed way.
Yeah, so I think the important thing about the communicating this information is that we really pay attention to the how of how we communicate it, and that we're providing information about why you shouldn't, why drinking might interfere with evidence collection or why smoking might interfere, but also that we are valuing the patient's choice and not, essentially not making them feel guilty for doing those things or feel like they've done something wrong if they've already done them. And often you're transferring patients from one jurisdiction to another, and when you go down this sort of the list of don't eat, drink, use the bathroom, smoke, change your clothes, and they really have to go to the bathroom and they do it, if they feel judgment, they may or may not share that information with you. So it really is about understanding how to communicate in a trauma-informed manner and provide information in a non-judgmental way. And we can do a whole training about trauma-informed care too. Can't fit it in this way.
Absolutely. The other thing I wanted to share with the group is collecting samples for substance-related rape. Currently, if it has been less than 12 hours since the potential exposure to a drug or chemical of some sort, then it's requested that both urine and blood be collected. After 12 hours, it's urine only. Of course, it's usually out of the blood by then and is only being excreted through the kidneys, so the urine is more important than the blood at that time. After 5 days, they recommend that we don't collect anything. What research has shown is that most of the time the half-life is so short that these drugs are gone out of the bloodstream and the urine by then. I will tell you that you will hear a lot on the media about substance-related rape, and they talk about GHB and ketamine and Rohypnol. The number one drug we still see and have seen for many years is alcohol and medications that are readily found. So anxiety medications, medications for ADHD are sometimes abused as well. So don't be thinking about the things necessarily that you might hear in the media. Alcohol is still a big one. And just as an FYI, if you do collect a chain of custody drug screen, so urine and blood, those do need to be refrigerated. The current physical evidence recovery kit, for the most part, can be put on a shelf and not need to be refrigerated unless there's something extremely wet in it. For example, a tampon and a PERT kit would require it to be refrigerated, but a chain of custody drug screen definitely needs to be refrigerated. We talked about strangulation at our last presentation. I just wanted to put this in there, though, to remind everyone that as part of a sexual assault exam, you want to screen for strangulation and the lethality of a strangulation. Patients can lose consciousness, we know, in less than 20 seconds, permanent brain damage in 3 minutes. And this is in adults, by the way, and death in 4 to 5 minutes. What's really scary to me is how many children we're having tell us now that they were strangled. They don't use those words, but they describe being strangled. And if it takes 3 minutes in an adult, it would take much less than a child. So I think it's something we really need to be thinking about when screening these patients, adult and children. Just wanted to share a few myths that I've heard regarding evidence collection. I continue to hear healthcare providers say that they have to call police. In the state of Virginia, an adult who is competent, who is sexually assaulted, has the right to choose whether they involve police or not. If it is a juvenile, then that may involve Child Protective Services. But just want to share, please let the adult competent patients have the right to choose whether law enforcement comes or not. They can have evidence collection even if they don't have police. I've had law enforcement say, well, he or she took a shower and so all the evidence washed away. The areas in a sexual assault that we gather some of the best evidence are parts that can't be showered away. So keep that in mind, and it's always better to at least try. Genital injuries in adults will confirm an assault occurred. That's not true. 50% of the exams we do in adults have absolutely no genital injuries, and less than 5% of kids will have genital injuries. So a normal exam doesn't mean the event didn't happen. And then lastly, I've heard that you only have 24 hours to collect evidence, or you only have 72 hours to collect evidence. That's old research. We now are using 120 hours, and again, you may want to be liberal with even those guidelines. Go ahead. So I'm going to leave you with a quick quiz before we start on Ruth's part. In which situations would biological evidence collection be offered? Vaginal penile penetration, anal penile penetration, oral assaults, digital fondling, mouth to breast, bites, or strangulation? In which one would you collect evidence? And the answer is all of them. Hopefully everybody got that one right. Ruth?
Okay. We're going to shift gears just a little bit and talk a little bit about screening, and in particular when a patient does not present with visible injury, or if it's a patient that presents with injury that you have some belief that they are a victim of sexual assault or domestic violence, intimate partner violence. But how do you establish protocols to screen, as well as sort of establishing the importance of screening? So I wanted to quickly go over some national stats, and these can vary from 1 in 3 to 1 in 4 to 1 in 5, but they're pretty consistent as long as we've been collecting some of this information. But 1 in 4 women and 1 in 9 men have experienced severe intimate partner physical violence or intimate partner sexual violence. And that's just pretty much across the board. 1 in 3 women and 1 in 4 men have experienced some form of physical violence by an intimate partner. And this includes a range of behaviors, some of which is illegal, some of which is not. 1 in 7 women and 1 in 25 men have been injured by an intimate partner. It's in some way at some point. And 1 in 5 women have been raped by an intimate partner. 1 in 4 women and 1 in 7 men have been victims of pretty severe violence over their lifetimes. So, and in Virginia, it's pretty much the same across the nation. And these are 2012 stats for Virginia, but they still hold true as we move forward. But you're looking at 17,664 domestic violence crimes that were reported to Virginia law enforcement. Many of those went unreported to law enforcement that will appear in a medical setting. And in 2012, Virginia law enforcement made 20,718 arrests for domestic violence. Unfortunately, only 26% of those arrests led to convictions. And there are approximately 31,000 or in 2012, and that number has actually gone up quite a bit, but 31,000 active protective orders on file. And in 2012, 117 Virginians were killed in domestic violence-related homicides. So this is, and again, the majority of those were killed with firearms, and that statistic remains pretty static as we move forward. So this is just a little overview of the prevalence of intimate partner violence. So, of course, with that much violence going on, we want folks to establish programs within their healthcare setting to screen for and address intimate partner violence and sexual violence. And these are just some of the basics that we need to establish before you begin a screening. And we really encourage healthcare facilities to connect with their local domestic violence and sexual assault organizations. And they are available in every jurisdiction in Virginia. And you can find that information out, if you don't know it, by contacting the statewide coalition. We'll be giving you that information at the end of this presentation. There also are a number of healthcare facilities who are establishing violence prevention programs, such as Bon Secours and VCU, that the Virginia Hospital and Healthcare Association are supporting, so reach out to them. Once you find out the folks that are involved in your community, you want to set up a collaborative work group so that you're working together and that you know what resources are available in your community. And you want to develop a protocol, so identifying who needs to be trained, what do folks need to be trained on. So for example, in your protocol, you might include, all of our personnel who will be interacting with patients needs to be trained in trauma-informed response before we implement screening process. And then you really want to have a protocol of how you're going to maintain and how you're going to implement this type of screening. So for example, you may want to start in one unit. So you may want to begin, if you have a women's healthcare unit, to start your screening there, or do it sort of start small and expand throughout your healthcare facility. So you're going to develop a method of screening. There are many options to do screening, and the CDC maintains a resource that lists all the screening tools that are the evidence-based screening tools that are available and the recommended settings in which to use them. And then you want to make sure you have the materials necessary to provide information to folks as you are asking for disclosures, or as folks disclose intimate partner violence or sexual assault. You want to be able to hand them something or hand your staff something so that they have something to take those next steps. And then lastly, you want to establish some sort of evaluation process. How can we show that what we're doing is working? So that's sort of a big, a quick overview of what you need to do to get started. Next slide. So one of the things that our organization and what we consider to be a trauma-informed approach, and we're really looking at, is providing what we call universal education, as opposed to those checklists that many of us are used to, like, are you safe at home? Have you been hit, kicked, things like that, that become very routine in our screening, and we have a tendency to just sort of go through a checklist. What we've found is that people are much more responsive to universal education. and particularly universal education that is healthy relationship-based. The CDC, again, has a comprehensive list of these screening tools, and the CUES screening tool, which we're going to talk about, is one of those. And then I think, yeah, let's just move on to that. So foundationally, what folks who are going to be screening or working with patients need to know how to do is how to be non-judgmental, how to actively listen, really listen for cues, really listen for what the patient is saying when they're sharing information. Then to offer information and support. And most importantly is to not push for disclosure. That tends to make folks sort of step back and be a little less reluctant to disclose. So the cues screening method is really a universal education method and has 3 fundamental aspects to that. One of those is confidentiality, providing universal education and empowerment, and that continued support. You can click next there, Davis. So confidentiality, which is very important to a trauma-informed response, as well as to helping to establish trust amongst patients, means that you have to know what your limits to confidentiality are. So we want you to be able to talk to patients about that the information they share won't be shared with anybody else, but that's not the case all the time. So it's important to know what your child abuse reporting requirements are and be able to share those. What your reporting requirements are as far as disclosure of weapons being used, and then to be able to establish sort of a script about how you will communicate that information to folks. You can go on to the next one. One of the really challenging things that happens for folks and is so vitally important is that patients are seeing for some aspect of their visit, and know is that it's really process or maintaining control, and a lot of coercive control that goes on with that. Very often, the patient and their partner may present with a partner seeming caring and attentive, and wants to be there for every aspect of the visit. So establishing some routine and some protocols around that allows you an opportunity to see the patient alone while you're doing the screening or the education is really important. And again, in a hospital setting where there's so much going on and it's very busy, this can be a challenge. So you want to really work that out before you start establishing a protocol. And then you want to make sure that all of your staff is trained on that protocol and understands that that's a fundamental aspect to the process. So I also wanted to provide you guys with a script. It's a possible script, something you can say around how you communicate limits to confidentiality. So you can talk to a patient and say, before we get started, I wanted to let you know that I won't share anything we talk about today outside of our care team, unless you were to tell me about child abuse or that you plan to harm yourself or another person. So those are some basic limits to confidentiality. So you can share that so folks know what to expect. And we have found that that does not limit people's desire to share, but it really helps to build trust and mutuality. So the importance of universal education. We go back to the prevalence of intimate partner violence and sexual violence. We find that it's really important that we establish some routines, that we are providing each patient with information. And that can feel overwhelming. So again, that's why we want to start small and establish this routine in this one section of your healthcare facility. But we encourage you to have information cards, and we're giving you a link to where you can get those, and that you provide each patient with 2 information cards as you begin your conversation about their relationship. And that as you provide them with these cards, you're not just handing them to them and saying, here's something for you, along with a whole stack of discharge papers or things like that, but that you actually open the card, or you, if it's not a folded card, that you actually hand that to the individual and look at it with them, and make sure that that patient is actually seeing that and knows that that's available. And again, we just want to offer that to everybody and establish a routine about how to give that information out. And a possible script for providing that information from what we call a healthy relationship perspective is to say to the individual, because healthy relationships are so important to your health, I'm giving 2 of these cards to all of my patients. You can keep one for yourself or share one with a friend or family member. There's information about where you can call about problems in your relationship or where you can get additional support. And if you practice that, it just becomes very routine and a part of how to provide somebody with information. Okay, next one. And then the support aspect of the CUES method is to make sure that the individual has continued support, and that if they disclose violence, that you feel prepared to provide a response. And I know that in training many healthcare providers over the years, people have shared with me, I just don't know what to say sometimes. What if they tell me this, they're having this awful experience, and then what do you say? And what's the right thing to say? And we're going to give you just a few words that you can say that provide a support to that individual and don't shut them down. We also believe connections in the community are so important. It's great that patients have somebody within the healthcare system to talk to. We want to encourage you to connect them with other programs in your community, and particularly intimate partner violence, domestic violence programs, and sexual assault programs. And then to end that visit with that connection to relationship health and physical health and emotional health. So you want to provide health promotion strategies. So just like you might say to someone, drinking or smoking is not good for you, is not healthy. Relationships that are abusive affect your physical health as well. So we want to make sure that you're getting the support you need as you leave here, just like you might give them information about a smoking cessation program. Okay. So possible scripts for that last part, or particularly if somebody shares some difficult information or discloses violence, some things that you can say that are considered trauma-informed and allow an individual to stay open, or something like, thank you for sharing this with me. I'm so sorry this is happening to you. what you're telling me makes me worried about your safety and your health. Or a lot of my patients experience things like this. There are resources that can help. In Virginia, there's a 24-hour hotline that you can call or text. And here in Richmond, we have a wonderful program called the YWCA, Women in Crisis. I'd be happy to connect you today if you would like. So these are just a couple of instances of things you can say. And again, I want to just share one of the things that is so important to not say are, oh my God, I can't believe that happened, or why did you stay with him? Asking those sorts of questions that really shut down the dialogue. These are scripts, or these are statements that you can make that help open and expand the dialogue. And then sort of to wrap this aspect up around developing some sort of protocol, the things to do to help sustain your program and those community connections. We really encourage you to partner with community and domestic violence or sexual assault programs. And again, you can find out, if you don't know what's in your community, you can contact the Virginia statewide hotline, and the number is up there on your screen. There's also an email address to reach out to the Virginia Sexual and Domestic Violence Action Alliance to find out what your local program is and how to connect with them, and to find out more about what's available in your community. There are other healthcare facilities that are doing this work that it's really important to reach out to and connect with, and you can find those out through the VHHA. Is that correct, Davis? Yeah, so really finding
Yes.
out and talking to, thank you, talking to folks who are doing this before you engage to really help you think through some of the things you need to think through. I encourage you to become a member of the statewide Domestic Violence and Sexual Assault Coalition, and you have access to training and technical assistance and support as you develop your programs. If you need folks to come in and work with your staff to set up a program, or just to have those partnerships as you move forward, it's a really helpful organization that you have available in Virginia. And I have a website up here that is the National Health Resource Center on Domestic Violence, that is operated by Futures Without Violence, who does incredible work around building and incorporating intimate partner violence and sexual assault programs into your healthcare facility. So I really urge you to reach out and look at the resources that they have available. They give you really step-by-step instructions as to how to establish a program, and they have materials available that you can print out and do a really wonderful job. So yeah, I think that's a wrap.
Well, I want to first extend a warm thank you to both Ruth and Bonnie for joining us and giving just such great information about such an important topic during such an important time. I think both are good partners as hopefully you all move forward in this work. And I know some of you may not be the folks who will be executing this work, but we certainly encourage you to partner with those at your facility and within your organizations that do. And if you are that individual, we encourage you to reach out to those that are on the screen now. This is the contact information for the folks that have been presenting for this series, and just a few of their expertises. I don't want to limit them, but if you have questions about these topics, please do not hesitate to reach out. As Ruth mentioned, if you have questions about beginning your own hospital-based violence intervention program, please reach out to me if you have questions, or Amy Vincent at VCU, who's been doing this work for quite a bit of time. I do want to open it up for questions. I know there's a lot of detailed information, and I do want to give you time to type your questions into the chat. I know I didn't see any as we went along, but I do hope that you all take a moment to think through some questions that you may still have after the presentation and put them into the chat, and we can answer them as we go. So please take a moment to do that. And while you're thinking of questions, I'll move forward to this slide to remind you that we do have another webinar focusing this time on gun violence and community violence. That'll be held the same time, noon to 1, on June 3rd, and that is a Wednesday, I believe. And again, that will kick off our gun violence awareness month and activities that VHHA Foundation and partners across the Commonwealth and the hospitals participating in our grants will be participating in. I'll point out one before we get to questions, and that is on June 5th, which is National Gun Violence Awareness Day. Our participating hospitals will be joining together to wear orange. We encourage you to do the same, and we'd love for you to share in that with us. So we will now go back to questions and see what we have in the question box here. Yeah, I can go back to the membership slide there, additional support slide. And then, will the slides be available? Absolutely. The whole entire presentation, the recordings, will be available as soon as we can get those loaded. They'll be presented in a YouTube format, so they'll be available to the public. But we'll absolutely send you those links to everyone who participated and to everyone who participated in the first one as well.
Annie asked a question I want to clarify.
Sure.
Annie, you'd asked, do you have a patient handout you can share with the patients? Are you speaking about the options for an exam, or are you speaking about, in general, resources for victims of sexual assault? Can you tell me more?
Annie, you can unmute yourself to answer that question. Let's see if I can do that.
Okay, thanks, Davis.
You're welcome.
Anything that would be like typically what you guys hand out to the patient. Beth and at Riverside may have some handouts probably that I'm not aware of, but just with the HVIP program, if we come across those folks who are needing some additional resources, did you guys create your own? Should we be creating our own? Or are there some generic handouts that we could be providing with resources and information to our patients? Or is there a link or somewhere where we can order those or get those for free, or how does that work?
Thanks, Annie.
So some of both. We have some that the forensic team already has that we hand out. Our new HVIP program is working on some as we speak, actually. They just talked about it yesterday. And then if I'm not mistaken, I'm going to put Amy on the spot. I believe we got some from VCU that she shared with us. Amy, am I right about that?
Yes, you are. We do have plenty of handouts that we use with all of our our survivors. And we're happy to share those with you.
Yeah, and I'll just add that link to the Futures Without Violence website. The healthcare website has safety cards that you can hand out, and you can also have them printed with local and Virginia information.
Annie, if you send an email to my email address that's on the screen there, I'll be happy to send you what we have. No need to reinvent the wheel.
Awesome. Thank you.
Right. Thank you all very much. As you can tell, it's a team effort. All of those folks are participants in our hospital-based violence intervention program collaborative, and we're so glad to show you that we're collaborating on so many different areas. Any other questions from the group? Any final words from our presenters?
I'll go while you're thinking of something, Bonnie. I just want to say how excited I am and folks in the domestic violence and sexual assault field to be having healthcare providers such an integral part of this work. You actually see many more folks than we do, than law enforcement does, than many systems do, and it is just so fabulous to have you giving out information and learning more and reaching out. I think it will make a big difference for people who've experienced violence. So thank you.
I completely concur with Ruth. Ruth and I have been doing this work for a little while, and I say that facetiously. We have always, tried to pull in more people, because this really does take a team effort when you are trying to help a survivor or patient, or the term that you use, of sexual assault and domestic violence. It takes everyone to be supportive and to use those trauma-informed techniques. And so the fact that healthcare providers are stepping up just makes us both very happy.
Well, I thank you both. I'll extend my thanks to you all if there aren't any other questions, because I think you all provide such a great opportunity for our hospitals, our community partners, to really see the great opportunities that can be presented to survivors of sexual and domestic violence and intimate partner violence. It's just really exciting to see this partnership and to see this work come to fruition. And I'm just terribly thankful for your expertise and your willingness to share it with us. And I will leave our participants with the thought of please don't hesitate to reach out to our presenters and to us at the Virginia Hospital and Healthcare Association. And please continue to take their action steps and look for ways to implement them at your facility and within your organization. And also mark your calendars for next week, as we're going to continue this discussion, just a little bit different angle, talking about gun violence and beginning the commemoration of Gun Violence Awareness Month. So I thank you all for joining us. And I thank you all for just your participation and your willingness to help people across the Commonwealth. So thank you all very much, and we look forward to seeing you next week. Bye.
Thank you.